Okay, folks, this is part 6 of module 7. Okay, so let's talk about treatment for depressive disorders. There's a lot of different treatments that have been found to be effective, and that's a good thing. So let's start with medications. Psychotropic meds. So the use of medication for depression is based on the idea that depression is caused by an imbalance in neurotransmitters or perhaps problems with neural receptors. So antidepressants increase the level of serotonin and or other neurotransmitters in the brain. SSRIs, selective serotonergic reuptake inhibitors, tend to be the first line of medication because they have fewer side effects than other antidepressants. If the client doesn't respond to those, then there are other options, right, that they then go ahead and try, including a family of drugs called the tricyclic antidepressants, which will target different neurotransmitters. Okay, so there can be a period where the person is sort of shopping for the right medication that works for them. It can be a little frustrating, and it can take a little time to find the one that works best. The research shows that antidepressants are more effective than placebos. So the question, do they work, is, yeah, it looks like they do. Okay, all antidepressants were more effective than placebo. What about cognitive behavioral therapy? Not all clients benefit from antidepressant medications, and some clients have side effects that just make it not an option for them. The good news is that cognitive behavioral therapy can work, and it shows to be about as effective as medication. So the cognitive perspective says people get depressed because of automatic distorted thoughts. So the goal of cognitive behavioral therapy is to identify, reevaluate, and change those negative thoughts associated with depression, right? And CBT can be combined with antidepressant meds too, and that combination is more effective than either one by itself. So that's a really powerful 1-2 punch, right? The cognitive behavioral therapy and an antidepressant. In terms of alternative treatments, I just remembered I didn't start my timer. There we go. For a kind of depression called seasonal affective disorder, or SAD, episodes of depression happen mostly in winter for these folks, and many will respond to phototherapy, which is exposure to high intensity light, right? A kind of full spectrum light source for a period of time each day, and that can help with the symptoms. For some people with depression, aerobic exercise can also help. Exercise releases endorphins, gives the person a feeling of well-being. Electroconvulsive therapy is very effective for those who have severe depression and nothing else has worked, right? It might even be a treatment of choice in some cases. For example, pregnant women who don't want to be taking medication that will cross into the developing fetus, or suicidal clients who are, in acute emergency and they need something that will work fast. Antidepressants take a while to kick in, whereas ECT works right away. However, ECT does have side effects. There's high relapse rates. So, usually a person's going to need to be doing this periodically. It's not just one and done. And there's a risk of memory loss. People report having like lapses in, memory for events leading up to the electroshock. Transcranial magnetic stimulation, right? The left prefrontal cortex can help with some cases of depression. The deep brain stimulation we've already talked about, which is not a sort of ongoing treatment now. It's still kind of a research and development situation. Okay, so here are the terms. Make sure you know them. What about bipolar disorder? So bipolar disorder requires medication. And there are medications that are mood stabilizers, like lithium. They work better than cognitive behavioral therapy, right? Talk therapy is not going to do the trick for bipolar disorder. You're going to need something like lithium or Seroquel, quetiapine. Now, quetiapine is actually an antipsychotic drug that's given to people with schizophrenia, but it can help some folks with bipolar disorder, especially if they have psychotic components to their mania, where when they're in the manic phase, they're losing touch with reality in some way. So combining lithium and say Seroquel can improve treatment outcomes. More effective again than talk therapy or cognitive behavioral therapy. Okay, so bipolar requires medication. Now, these drugs often have side effects. Those side effects tend to diminish after a few weeks, but they can be unpleasant and they can represent a barrier where people start taking the medicine and then stop, right, before they've managed to sort of push through to the diminishment phase. So compliance with medication can be an issue. Sometimes people also miss the mania where they were feeling so super awesome, and they might, decide to just go off the meds so that they can have that feeling back. And what about schizophrenia? So there's a group of drugs known as the atypical antipsychotic medications. They are the current best treatment for schizophrenia. Back in the day, before we had antipsychotic drugs, prior to the 1950s, psychotic people were very hard to treat. They were generally institutionalized. That's what these pictures are showing, right? People who are in like fetal position. Sometimes you got to put people in, what do you call those? The outfits where they're like wrapped up tight. I can't remember the name of them right now. Straight jacket. There we go. Or padded cells, right? Because there just were no medications that were effective. So, the whole point was to make them more manageable as opposed to help their symptoms. Likewise, lobotomy, brain surgery like lobotomy was often used for severely disordered psychotic patients, which might have made them easier to treat, or at least easier to handle, but it really did not address their symptoms. It just created this sort of zombified state, right, where they were passive. So early antipsychotic drugs, those are the conventional antipsychotics, they were able to reduce positive symptoms of schizophrenia, right? The delusions, the hallucinations, the disorganized speech, the weird behavior. And these drugs really revolutionized the way people with schizophrenia were treated, leading to a lot of people leaving long care facilities and a lot of institutions shutting down. But they don't impact negative symptoms, right? All the losses that some people with schizophrenia show. And they have significant high risk of side effects like tardive dyskinesia, which is muscle spasms and uncontrollable, either of the face or the arms and legs, these uncontrollable tics. So late 1980s, a new group of drugs finally enters, the atypical antipsychotics. They act on different neurotransmitters than the conventional ones. They can, in fact, impact some negative symptoms as well as positive ones. So that's a big plus. They're also less likely to cause side effects like tardive dyskinesia. And so now they are the drug of choice for schizophrenia, right? And again, schizophrenia requires medication. Talk therapy isn't going to do it. All right. So what about personality disorders? Can we treat those? They are notoriously difficult to treat. People with these disorders tend to see the world, the environment, as being the problem, right? Like it's other people who can't handle me. So they don't really seek help. Still, there are some therapies that might help for borderline personality disorder. And we'll also look at less successful efforts to treat antisocial personality too. So let's start with the therapy of choice for borderline, which is DBT, dialectical behavior therapy, developed by Marshall Linehan, who is a psychologist who also has borderline personality disorder. At least, for a while she thought she did. Now there's some question as to whether she does or not, but she was in a unique position to be able to come up with a therapy to kind of help here. And it addresses this tricky issue of, on the one hand, accepting that one is, the borderline person is going to be a highly emotional, intensely feeling individual, right? Like this is you, that's not going to change. But on the other hand, trying to make life changes, life choices to reduce the intensity of those emotional responses, right? Like accept that this is you and now make different choices to try to give yourself a calmer life. So this has been shown to be helpful. There's sort of three phases to this therapy. Phase one, the extreme dysfunctional behaviors are targeted. So the self-harm, the suicide attempts, those fires have to be put out. And the focus is on replacing them with some less destructive behaviors and teaching ways of coping with the intense emotions that go with those behaviors. And then phase two, for most people, they have to address the past trauma. Remember that 70 to 80% of people with this diagnosis have been abused, right? So dealing with the abuse. And then phase three, the focus being on developing self-respect and independent problem solving, right? So like loving oneself and learning how to manage, the high emotional person that one is. So the research shows people with borderline personality disorder are less likely to be suicidal, more likely to stay in therapy when it's this kind of therapy. And, we can call that a win too. So what about the other personality disorder we looked at, antisocial personality disorder? It turns out it's really hard to treat. I mean, think about it. These clients lie. These clients don't care about other people's feelings. They don't seem to experience punishment as unpleasant. So aversive therapies don't work. And they don't think a whole lot about the future. So they're not worrying in the moment about if I get caught, I'll go to prison. Right. So all of these combine to make it a hard thing to treat. And part of it is that developing a therapeutic relationship is difficult because they're going to lie to you. So one form of therapy they've tried involves using stimulants to increase levels of arousal in the cortex that are under-aroused for people with APD. There have been short-term effects that have been reported, but nothing long-term, nothing big. They've tried anti-anxiety drugs. They've tried lithium. Those might reduce the hostility and the impulsive aggression, but overall, these are brief, inconsistent, and small effects. So again, not very effective. What about talk therapies? Most talk therapies don't have an effect either. Behavior therapy using operant procedures can be helpful, but it only works when the therapist has lots of control over the client's environment, right? So if the person is in prison and you're the prison psychologist, you can set up protocols where, they're reinforced for doing the right thing and punished for doing the wrong thing, and you'll get them to comply. But as soon as they're out of that controlled environment, they go back to their old ways. So prognosis is pretty poor, even more so with people with psychopathy, which seems to be kind of a more severe thing. So what about treatment for kids and adolescents? So in the US, from 12 to 20% of kids experience psychological disorders, and problems that don't get treated in childhood just travel with the kid into their adult life. So there's benefit to getting early treatment, right? So let's look at autism spectrum disorder. How can we help kids with autism? So the core symptoms are impaired communication, restricted interests, deficits in social interaction. The client, especially in cases of severe autism, may also have physical behaviors like meltdowns, which is what we're seeing in the picture here, and possibly self-harm behaviors like, biting oneself. Those need to be addressed first because they're kind of fires you need to put out. So structured therapies like behavior therapy can be more effective than unstructured ones like, play therapy. One effective behavioral treatment is called applied behavioral analysis. It's a highly structured therapy where for at least 40 hours a week, the parents and teachers and therapists use operant conditioning. This is with like preschool age kids, 3-4-year-old kids, where you heavily reinforce the things you want to see. And in one study back in the 80s, this led to IQ gains of up to 20 points for kids, many of whom went on to enter normal kindergarten programs, whereas none of the controls showed this improvement. I don't like the fact that this is 1980s data. Where's the recent research here? Okay. And then we come to ADHD. So there's a few things that can help people with ADHD. One thing to point out, kids with ADHD are more at risk for other psychiatric disorders than kids without ADHD, things like anxiety disorders and depression. So effective early treatment is crucial and helpful. Medications. The most common treatment for ADHD is a central nervous system stimulant. like methylphenidate, which is Ritalin, or another drug, Adderall, which contains amphetamine. These drugs stimulate activity in the frontal lobes, which are underactive for kids with ADHD. So that supports cognition, impulse control, focus. At appropriate doses, they decrease overactivity and distractibility, and they increase attention and concentration. Now, there's no free lunch in life. There are drawbacks to these drugs. These are stimulants, so no surprise, kids may have sleep problems, reduced appetite, twitchy kind of behaviors, temporary slowing of growth, and potential for abuse when people who don't have ADHD take them. Also, kids on medication might perceive their problem as being outside their control, right? Well, it's not my fault. I have ADHD. I'm on meds. And so they're not doing other things that they could be doing to help their situation. Most therapists believe medication should be supplemented with other therapies, like a talk therapy, for example, or behavior therapy, right? So getting those, sticker charts out, using operant procedures to reinforce appropriate behaviors and to reinforce habits that you want the person to develop. And there's good evidence this strategy can help people with ADHD, right? So using the behavior therapy plus medication can be particularly helpful. Okay. Woohoo, we got to the end, folks. I'm going to stop the recording. Bye for now.